Thank you very much. I know that we are running a little bit behind time, so I'm going to do my best to talk as not quickly as I can, but as concisely as I can. My name is Hallie Zeleznik, and I'm a physical therapist, and I work for UPMC Centers for Rehab Services. And, you know, I really would like to thank everybody for inviting me to reflect on Dr. Friedman's presentation. I listened to it several times, and each time I listened, I started to think about another line of thought that I could perhaps talk about today. But I think what Stephen Hunter said rings true for me as well. There's not, you know, I can't say that we're here and we've arrived. We're simply just continuing to be on our way. And it's funny because I recently read an article this morning where Matthew McConaughey said something about it's never about the arrival because you never truly arrive. It's about your process of getting there. And so I just kind of want to tap into a couple of key components that I thought were reviewed earlier today. Let's see. Okay, spacebar. So just a really quick overview of our health system. We have a very large health system here in Pittsburgh. It actually covers all of Western Pennsylvania from the Ohio border over to around the middle of the state to an area called Altoona and further out to a region called Susquehanna and Williamsport. And then up to Erie, which borders the New York state line, and then down into Uniontown in the very southern corner, southwest corner of the state. And as you can see, we have multiple hospitals, physicians, services, cancer centers, and we are collectively, the Centers for Rehab portion are collectively the largest network of rehab services. And from a rehab perspective, we provide the PT, OT, and speech services in 19 of our acute care hospitals, 8 of our skilled nursing facilities, 8 inpatient rehab facilities, more than 70 outpatient locations. And we have a strong academic partnership with the Schools of Health and Rehab Sciences at the University of Pittsburgh. So what I really wanted to tap into today were a few things that Dr. Friedman covered, and those things that I really thought about were that idea of embraced uncertainty, infrastructure, and then developing the learning community. And I've seen I've been watching the chat, I've been watching the question and answer box, and I see a lot of questions coming around about the learning community. And I'm glad to say that I'm going to discuss that a little bit today, how I think we've done a nice job at achieving that. But first, I want to touch on infrastructure because I do think that it's key. And here at UPMC, one of the things that I think we've really kind of come along on when I think about this idea of the learning community and the infrastructure is not necessarily that each individual portion has been developed instrumentally on its own in some sort of fashion that we can follow over time, but more so that we've been tapping into all of these different components that are really helping to build our infrastructure. And maybe it doesn't happen sequentially or in a specific order, but those elements are there and they continue to strengthen. And I think we continue to identify our gaps and where we can fill those gaps in. One of the things I wanted to talk about was that idea of capturing that measurable performance and then turning that performance into data. And I think the biggest way that we do that, just as others have stated today, is through our electronic medical record. And what's interesting about UPMC is that we actually utilize 2 large medical records. So our hospitals are on 1 large medical record system that I'm sure everybody would know the name of here, and then our outpatient sites. And this is not specific to rehab. This is truly all of medicine. Our entire practice is on another large EMR that I think everybody else would also know about that one as well. And so that I think historically has been a challenge, but the beauty of that is that within UPMC is that there are different groups that are working to try to collect that data and turn that data into usable data. We have 1 large team that is an analytics team, and they simply work to pull the data from both EMRs and compile that data into a web-based platform that is usable. So essentially you're able to collect data from the inpatient records as well as the outpatient records. And about a year ago, UPMC Centers for Rehab Services has connected with this clinical analytics team, and we've been able to design a dashboard that's pulling data from both areas so that we can start to merge and get that information as well. I did say I'd spend some time talking about learning communities, and I couldn't agree with Dr. Friedman more. I think that this has been huge, and I really want to talk about them kind of in the context of one small project with a lot of future aims that we've been working on over time. And so I want to think about this through the lens of implementing some standardized performance-based outcome measures across our inpatient and outpatient settings. And while this in and of itself is not necessarily solving a wicked problem, I was a little bit worried that my wicked problem wasn't a wicked enough problem when I heard that we were solving the idea of cardiac events in the community. However, I do believe that if we're not able to measure our performance and what we're doing with our patients across the continuum of care, it's going to get harder and harder to do things like improve our transitions of care or address hospital readmissions or address function in the community and to identify our patients who are at risk. So essentially what we did was we kind of took a knowledge translation approach when we did this. And one of the big things that we did was we created a group of clinical champions. And I really liked this idea of starting at 12 o'clock versus starting at 5 o'clock. And this project really did grow out of a clinician group. And so essentially we had a group of clinicians who were interested in coming up with a set of outcome measures that we could utilize across patients, both in the inpatient hospital on the acute care side, as well as inpatient rehab, as well as the outpatient side as well. And so with a small group of interested clinicians, at the same time, we had some folks from the organizational standpoint who were interested in looking at utilizing outcome measures to support discharge recommendations and to essentially eventually look back and see if we could start to identify those at-risk patient populations, perhaps who are at risk of being readmitted within 30 days and or at risk of having falls or whatever that problem might be. And essentially what we decided was that we wanted this to be a very clinically run group. And so what we did was we pulled a group of clinicians together that represented the physical therapists, the occupational therapists, and the speech language pathologists across all of our hospitals, both from acute care and inpatient rehab, if they did have those settings of care, as well as on our outpatient side with individuals from certain specific programs that were related to some of our initial goals. And so those clinical champions really truly, their goal and their role is to bring forward their ideas in the context of their own personal daily practice at their own facility. Again, thinking of all the different facilities and all the different locations we're at, there's a lot of differences and a lot of places variability can creep in and a lot of different workflows that we're considering. And one of the things that we had asked for when we built this clinical champion group was essentially we wanted our rehab directors, the individuals overseeing the programs and overseeing the hospitals, to identify individuals who had a passion for outcome measures or who were interested in taking another step in their career and becoming involved in some program development or process improvement. And so that's essentially how we got our clinical champion work group. Were through volunteers. And I know Dr. Friedman had mentioned that in one of the answers to one of the questions that he proposed. I did see a question through the chat, and I'm hoping to address that now, because the question in the chat essentially asked about some thoughts on, yes, you can have this ground up, this grassroots effort from a clinical champion group, but then how do you get that organizational or that leadership buy-in? And essentially what I did, I think, in my role as a go-between was I took what the clinical champions wanted to do and I created a project proposal and I proposed it to one of our vice presidents and to our CEO and COO. And I essentially turned what they wanted to do into valuable, meaningful goals for our entire organization, as well as all of our rehab service line. And they were in support of that. And so there you go. And they became supportive of the project. But it didn't just end there, because not only do we have a clinical champion work group for PTOT and speech, but we also have an oversight committee. And that oversight committee is essentially the leadership. And what that does is A, it keeps them informed as to what kinds of ideas the clinical champions are coming up with. And then B, it allows them to essentially have their voice be heard as well, because we know that that's important. And so with our clinical champions, we really did purposely have some overlap between that oversight group and that clinical champion work group. We utilized a knowledge broker who essentially was the leader of the clinical champion work group, who was familiar with the evidence, who was able to lead a group of clinicians in assisting them in coming up with their own decisions rather than imposing what our ideas or our decisions we think should happen. And we essentially would try to pose questions to the group. And the biggest thing is that embrace uncertainty. And, you know, you have to be open to what they're going to say. There are a lot of questions that we would pose to the group, such as what measures do we want to use? Or how do we want to use these measures? Or how does a clinician determine which measures to use? Which are in, which are out? What do we do with that? There are a lot of answers that came out of that that I don't know that I 100% would agree with. But that's that embraced uncertainty, you know, so if that's what they feel is going to work for their workflow and that's what they feel is going to be important to the level of care that they provide on a daily basis, then I feel like it's our duty to follow through on what their suggestions are. And then when you follow that whole idea of that whole learning health, that learning structure, what's going to happen is as we pull that data, we'll be able to pull it on the back end and give it back to the clinicians and say, here's the data. Did it show what you wanted it to show? Are there questions that you still need to have answered? Do we need to adjust what we're doing because you're not able to show what you want to do? show. And I think that's that key idea of embrace uncertainty. And I think our leadership also kind of has taken a big role in that embrace uncertainty as well, by giving the clinicians the power to make those decisions and then supporting them through those decisions. And so it's that kind of continuous effort and cyclic activity. And I'm actually going to stop right there because, again, I know we're short on time and I want to leave time for all of the questions that are coming through. But again, I just want to thank everybody and thank you for letting me be a part of this.